And an EBUS scope is this right here. And this is what plugs into the ultrasound processor itself, which is down here called the SU1. When it comes to you, you'll see that the lid has been taken off of this. There is a lid that fastens on this. Typically, we recommend that we just keep it right here by the scope. So I'm not sure where that is, if it's back into the cleaning area. But the big thing is, if it comes and that lid is clasped on, you'll see there are two metal ridges. There are literally metal pieces that go in those ridges, and the locks are on this side. You lift them up and that whole thing will come off. It is absolutely critical that that be put on before it's reprocessed, or of course you could damage the pins in here and it could damage the scope. If they send it with you, we recommend you put it on, again making sure that those notches are filled in. If they don't, then obviously they'll take care of that back in reprocessing, just to let you know. So when you first bring the equipment, you want to make sure it's powered up. It does take a little bit to fire on, and so the power button is here, and for the SE1 processor is down on the side. That looks like a power button, but it isn't, so we do like to make sure to point out that difference. And at any point as we're going through this, if you have questions, please stop me. Any question is relevant, because if you're thinking it, it's possible that someone else is thinking it as well.
So this one is not the power button?
Right, so this is your standard bronchoscope. So this is the light source and the processor. But you have the additional processor that's required for the ultrasound, and that is this one down here, the SU1 Platinum. So it will have to be on too. And notice when they come on and they're ready, they all have this orange light. That orange light means it is in standby mode. You do not ever want to plug the scopes in or remove them unless it is in standby mode. So I'm going to show you what it looks like when it's out of standby mode. All right. Okay. Not wanting to go out of standby mode for me. It may not be fully warmed up yet, so I'll wait and show you that in a minute. Because it does take approximately 3 to 5 minutes for the system to get fully ready to go. But you saw how that was in here where it was already plugged in and it was off? We don't recommend that. We recommend it be powered up first, be in standby mode, and then plug it in. Oh, regular? Okay. Now, when you are plugging it in, because it is in standby mode, there are 3 ways you do that. This is going to go down here. Notice there are dots that line up on both the processor itself and this. So you'll want to line those dots up and simply lock it by moving the lever to the right. You will feel that it is locked in place. Now, when you push it, and when we're done, I would like you all to feel how that feels. It doesn't like click in. You just feel it finally get to where it needs to go, and then you'll lock it. But if for any reason there's any movement in this, it's probably not seated properly, so please do it again. Now, we're going to, again, plug in the scope. From a scope handling perspective, you always want there to be as little coiling as possible in this area right here. So you saw the way that was all, you don't want to plug it in like that, where there's a loop, you see? You want to make sure that you are plugging it in with the least amount of play. And part of the reason for that is too, is that that is going to give the doctor the biggest amount of space to pull it out. And they just, we have people coming in. So this goes into your light source. It usually will come with the cap attached. Obviously, you will want to remove the cap. And again, you see they have guides here. There's a dot that's on the top of this that's going to line up with it. And you'll push that in, and again, to the right. Righty-tighty, lefty-loosey on all of our equipment. So it goes to the right down here, and it goes to the right here. The actual scope itself, the main differences are two. As you can see, the tip of this scope has that gray portion. That's called the transducer. That's actually the portion that is sending out the ultrasound waves and receiving them back in order to create the ultrasound image. The end of this will get a balloon attached to it. That's very different, of course, than your standard bronchoscope. And this little area back here, opposite your biopsy port, is where the syringe is going to get attached. We recommend a very small syringe, no more than 3 ml or 5 ml, filled with your sterile water, or whichever water that you're using for this procedure. And once the balloon is affixed, we will test it and make sure that it is filling properly. Okay?
Is it a slip tip syringe or a lure lock?
No, it'll need to be a lure lock so that it can attach right to this and stay on there. Because the doctor will, once it's positioned properly or once he's inside, want to squeeze that and enlarge that balloon, which is very small, it's not nearly as big as my hand, and withdraw. So it will stay on there during the procedure. So again, we recommend nothing more than 3 or 5 because of that. Also, if you get much bigger, it starts getting in the way.
So how many mLs in that balloon hold?
We recommend no more than 2 to 3 max in there. And we're going to show you. I'm going to go through the whole thing and show you. So the suction, and it looks like they have one already pulled out here. This is the suction, which is going to go in the very top here where this is. This moves around, and it's important, if you look inside here, there's a tiny little notch, and again, I'm going to have you all do this, but up in kind of the like 2 o'clock position, there's a little notch, and that little notch corresponds to a notch on here. And so it's important when you get this into place, it'll kind of seep in there and you'll feel it's not going to come out. And then this can move in any direction. So the doctor, depending on whether they're right-handed or left-handed, can move that section around. And that's nice because again, it just gives them a little more ergonomics when they have to get in there, and sometimes they're really torquing it to get down the specific pathways they need to go into. So this will be fitted as well onto the scope. And then, depending on where they're at with things, you usually will start with a forceps cover on there. Because our scope, the way this is designed, it has a 10-degree forward viewing angle. And we'll show you what that looks like on the screen as well. But what that means is the doctors can use it as a standard bronchoscope before they turn on the EBUS portion if they want. And that's nice because sometimes if they're doing ultrasound procedures, they end up using 2 scopes. They'll start with the standard bronch, go in, and then they pull out, and then they switch scopes, and they go in with the ultrasound. It is not a requirement you do that with ours. If the doctors are comfortable, they can use that as a standard scope without, the balloon or with it. Again, also, it is not a requirement that the balloon be used with the transducer. If this is directly touching the skin, you will get an image on the inside. My understanding is that Dr. Singh prefers to use the balloon. That's what I have heard. So in that case, we'll want to make sure that we put that on and test it. So if someone could get me the 3 ml syringe, that would be great. So we'll get that filled with water.
What's on the side? You want a lure lock? 3 ml lure?
Yeah, it'll have to have a lure lock. Please, thank you.
Mm-hmm.
The balloons are right here on the chart. Yeah, those are
Yeah, it's a 10.
and it will say right here on the box, balloon for ultrasonography. These only come from Fuji film. So these need to be ordered directly from us. We have quite a few currently here. In the event they start doing quite a few additional procedures, we want to make sure that they get those ordered.
The second case canceled. The second beat is so we have this.
So we only have one now? Okay. I know, well, originally I think we started with 4, now we're down to 1. So hopefully that one won't cancel so you can actually see it in action.
She said he had a 5, that's all.
Okay, that's fine.
We'll have 3.
We just need some standard, water, saline,
Or sterile water, which is
That would, we prefer sterile water, is our choice in using it because we want to keep everything as clean as possible. These do come in sterile packs. Now, we do recommend, unless this has been cleaned just recently, we have an alcohol pad to just wipe this down. I don't know if this is in a sterile pack when you start, obviously that's fine. But since this was just sitting here, I'm concerned that maybe, who knows how many people have picked it up or.
I'll get you one.
Oh, we got one of those pockets here, hold on.
All right.
I got you right here, bro.
You're awesome, thank you. And so, again, it's really because you just, obviously, anything that we can do to reduce potential for infection, we want to do. I always tell people when it comes to your scopes, and this is whether you're reprocessing it or, you're in the room trying to clean it like it's going to get used on you. If you think about it that way, then you're always going to want to do the best in terms of your infection control. So, this is a sterile pack that it comes in, and they are super tiny. So, if you haven't seen these before, I want to be very careful so we don't drop it on the ground. I want to show you, look at how totally tiny
Oh, no.
this little balloon is, right?
And that's the only one in that pack?
It's the only one because
Oh,
they
wow.
come individually sterile packed.
That's a lot of balloon, man.
Yeah, I know, right? And so you want to take the fat end and push the clamps in to the fat end, just like that. And trust me, you'll need to practice this a few times because it doesn't, it's not something natural to put on something so small, right? So again, I recommend you do it over your workspace because, trust me, the first couple times you try, it's going to be pew, shooting your eye, So you want to be careful. So what you'll want to do is just stretch that balloon out wide enough that you can get that transducer up inside it. And ideally, if you can get this second piece on here, that's even better because that makes it easier for getting the edge of it on there too. Because what you'll see is there's little tiny grooves that the ridges of this sit in. So again, you get it on there, you're going to want to hold it open. And you want to try to not touch the metal to the end of the tip. And the reason why is that transducer is literally the most expensive part of this scope. It has little crystals in it. The whole thing, if it needs to be repaired, is over $12,000 just to replace this little tip. So that's why you want to be super careful. You're going to slide that tip in there and see how that just popped out the top like that? That's perfect. And then you kind of want to just slide. And trust me, this takes a little work. You might have to use your finger a little bit. And we're going to get this bad boy off of here. Trust me. Always give yourself a lot of extra time for setup of these cases. I say that typically for a standard bronch case, your setup can be anywhere, say, 10, 15 minutes max to get everything all ready to go. With this, I would give yourself, until you get used to them, because you don't do a lot of them here, I would give yourself at least 25 to 30 minutes, right? If at all possible, until you start getting used to it. And then what you're gonna do is just make sure, and it takes a little work, that you get this balloon down into the groove. And these balloons are very tough. So as long as you're wearing gloves and you don't have super long fingernails or anything like that, you should be fine. And if you'll see now, the edge of this is down inside this little groove. You see that? And pulling them off is a little easier. Can you see there's that little groove? Yeah, you'll have to get real close.
Oh, just above that
Yes.
dot in the back.
Yep, so there's a groove along the top here, and then there's a groove along the bottom. And it probably won't show up too clear on the phone, I don't think. But you'll want to make sure that that's fitted there. Okay, so we're gonna go ahead and draw up some of the liquid into the syringe. Yeah, so I'm gonna put it right at 3. And hopefully, now that I've shown you how to do this, we won't just blow it right off, right? So we're gonna feed that in. And you always want to test this. Oh, look. Woo! There we go. It's filling with the water. And so that's about all that it's going to take. It's fully in there now. And you can just simply draw it back out. And then you have tested it, you know that it did. And see how there's a tiny little bit of air there?
Yeah, I was gonna ask you
Just
about
take
that.
your fingers and press that air out of there. Squeeze it. Again, don't scratch that transducer, but you can squeeze on the sides and get that air out of there. Remember, what's the enemy of ultrasound? Air, right. So we want as little air in there as possible. And so again, if you still see kind of a little bubble of air, just pull it away from that and press in. So now the balloon has been tested, everything. Now let's make sure here. So now, when you're ready for the case, all 3 of these need to go out of standby mode. And I simply pressed and held that. There was a little beep. I pressed that. And this one, you can see where it says standby. You literally just press that in until that orange light goes away. And it seems like a ridiculously long amount of time to me. It's about 8 to 10 seconds, depending on how quickly you count, see? And then once that goes off, you'll notice you have all green or blue lights. That means we are go. And you'll notice that's when you can see the light for the balloon. You'll see that because that's going to be. And where the light is also just below that is the instrument channel. So that's where that sheet is going to come out, and you'll see that on the picture. So let's go ahead and get these monitors going here. Let's see. So this is just the keyboard for this processor up here. But this, why is this not? Okay, it's coming up here.
Yeah.
Pardon? So this processor is what feeds that image over there. So if it doesn't come on, yeah, so that's the EUS processor. That's what's feeding that image right there. And what you're seeing right now is the end of that tip with the balloon on it, right? So a couple things for the EBUS. You'll see there's a little thing here, it says EBUS bronch. That's super important. That's picture in picture. So if I press that button, that's going to be the view if they're using it, if he's just going in to get where he needs to go. That's your standard bronch view, okay? When you press that picture in picture, it's going to bring up, say, unfreeze it. Sorry, you have to hit, this button will be orange and you hit unfreeze. So I'm just going to show you kind of against my finger. Now, granted, it's not going to see much through your glove, but that's your ultrasound image. And if you hit it the third time, down here, continue to have the visual where he's going into the lungs and the airways. And then this will be, again, once it's touching the area of interest, is where you're going to see that image. Couple things here. Where it says biopsy, that's really important. We recommend that always be pressed. You see how this brings up a green line right here. That green line is the angle that the needle is going to go into, that it's going to come out of the scope. So ideally, you would like to position your mass above the blue mark in here. And each of the green dots is 1 centimeter apart, and the smaller green dot is a 0.5 centimeter measurement. So you can actually kind of gauge the size of the mass even without measuring it formally, just by looking at that line. And ideally, the doctor's going to want to position that line directly where the mass is. So in fact, the closer it can come up to the transducer, obviously, the closer you can be, the higher chance and probability that you're going to be able to get a very good sample. And so the doctor will want to position it there. Once it is in position, the doctor may lock it in place. And then at that point, the doctor will ask for assistance. Now, we recommend, can you hand me one of your needles, please?
Do we bring one down? Can you bring one down?
Okay, great.
So while he's waiting on a needle, so we're gonna put, once the screen comes up, we're gonna push EBUS.
Right.
Okay, and that's
Well,
gonna,
when he tells you he's ready.
right, but that's gonna be the first one. Then we're gonna push it again to get the ultrasound curve.
Right.
We're gonna push it again to get the scope
Right.
curve.
Depending on how it comes up is depending on how it was when it got turned off the time before too.
Oh, okay.
So
Okay.
it may be in this mode when it was turned off, but no matter how many times you press it, it's only going to go through those three options.
steps. Okay.
Okay. So that's not a problem. Also, if the doctor wants to measure, there's a measuring button right here. So what that's going to do is they'll use the roller ball. So let's say they position it. Here's the mass. They're going to get it on one edge, hit the measure button, and oops, I'm sorry. So we're going to set that with the set button and come over here. And then again, hit it with the set. So that's going to take a measurement. There it is. It shows that distance right on the screen. And so at that point, the doctor may choose to trigger and take a picture of that. It just depends. The trigger button is right here. And that's all hooked up to your system. So that should automatically send those images across.
Who will be doing that part? Will the doctor be doing that part?
So typically, yes, but let's be very clear, if he's in there and holding a tool, both his hands are gonna be utilized, so, or hers. So you're gonna definitely need to know those things. Also, if they want to annotate and type something, they can take that up. Let's say they wanna bring that up by the mass and type something in. You know, if they want to do something like that, they would hit the annotate and then come down and type with the screen. So, well, Okay. Oh, I'm sorry. No, they don't do that. I'm sorry. I'm thinking of, we're gonna hit the keyboard right there. There's a little keyboard button, and then that brings that up.
Where was it?
Okay, so when you hit annotate, it's so annotate. Oops, annotate. See right here where it says keyboard on the screen? You hit keyboard and they can type that in. If they want to delete it, there's a delete button. Some doctors use all of that stuff a lot. I don't know about Dr. Singh because this will be the first time I'll be observing a case with him. And for this first case, I'm happy to do that. But he's done these cases before, so he should know these things. But if he doesn't and needs a reminder, I just want to make sure everybody who's helping with the case for respiratory should at least have this basic functionality. Understood? And again, the freeze is, it turns on and off the scope, the transducer essentially. So we just like to point that out. Now the settings for like gain and frequency and all these things that relate to the EUS picture have already been set. You are not expected to understand or know what all of those things do. I am not an expert on what all of those things do because we have specific ultrasound specialists who have set all those things when the equipment was set up. So the only two things I will say is that he says I want it a little brighter, and I would like to have someone label this. I think it would be a benefit to do. If he wants it a little brighter, gain up and down is brightness. So if you have a label maker, I think that would be good to put brightness next to the gain button, because gain is, I mean, I don't, you know, unless you knew that, nobody's gonna think, oh, I want it brighter. I'd be like, I don't know. And DR is dynamic range, and dynamic range is gonna make clear, it's gonna give you a little clarity or make things a little smoother up and down, okay? So when we're done, I will find the label maker and we'll get those two things labeled, okay? So I just want to point that out, that there's really, those are the only things that you're gonna need to touch on this keyboard. Biopsy, which again, shows the line,
Right.
1 inch between each of the big dots, or 1 centimeter, excuse me, 1/2 centimeter with the smaller dot. The annotation and measure. The measure, you use the set and the trackball to get where you need to go. And then the gain for brightness, the clarity with the dynamic range. Again, basic settings for those things have already been set. Thank you. And as I said, I had asked if the Boston Scientific rep could be here, and I think it would be of value to have them come in another time and review with you, because I can show you how to put it on and I can show you the basic process, but I can't give you technique, you know,
So this is for our old elective.
That's not
legal. This is not EBUS.
is this,
So that work.
we're gonna find out. Because we definitely need to know that.
I don't want to mess up anything. I'm just saying this is.
No, well, I don't know. I have not seen it. I'm used to ones where it actually has like a little clip that clips over this, and then the whole needle mechanism goes down. So
Yeah, that
honestly,
clip.
I have not
So the
seen
one
it.
you sent me to Central has a clip in it. That little pink, little white thing like this?
Yeah, and it
Then it
clips
sits in there.
right.
Yeah, that's what the needles go to.
Oh, no. I know what
You
you're
know what I'm talking about?
That's for the syringe on.
Yeah.
And irrigate. No, that's not.
That's not what
this
she's
is
asking for?
Yeah, this
Oh, okay.
is not. Because
for
typically
everyone.
they'll have the set, and I'm sorry.
No,
I
but that's
should
not the
have
piece she's
opened
looking
this.
for.
That's okay. I didn't think that would work because
She's
that's.
telling them to find out what they
Okay.
use.
Yeah, because it is typically what you'll see, it's actually a little plastic piece that clips on to the biopsy
Now
board.
we have caps to go on.
No, it's not the cap, it's not a cap like
So do we
this.
even-
Oh,
This
you
is
got that.
actually
Okay.
something that holds the needle in place.
Do we even have anything for the
Okay,
case?
so,
I hope they do. We don't have any of the food.
We don't do
supplies,
any of
of
the stock, and we've never had anything to do with EBUS.
So we don't.
But he's been doing it, right? So they got
But
it
they've
here.
been doing it down here,
Stuff in
so.
these boxes here, what is it?
No, these are the balloons.
Oh,
These
okay.
are the little balloons, or as we like to call them, the condoms.
Is both of those boxes there?
All three of them.
Oh, okay.
Isn't that funny? That's what they call them. It just makes me laugh.
No, that's not it.
No, so they don't have needles for our equipment up in their section. So what kind of needles is Dr. Singh using? Well, whatever he's sampling with on the EBUS.
This is aspiration here.
Okay. And then there should be a little white fastener that attaches to it. And I do think I remember somebody telling me they did use Olympus needles here. And that may be why someone may not have wanted to come in. Unfortunately, Olympus and us are two big competitors, and sometimes people get a little at their back up when they're asked to co-train, which is silly to me because we're all in the same space, you know. We all gotta.
This came from the model of camera.
Okay.
But this thing.
Wow.
They give it where you
I'm not used to this kind of needle here. So I'm not,
They might could do that case today. Well, he's been doing them down there. I mean, I don't know what he's been doing.
Huh?
This is the piece that I think we're gonna make this work here. This is definitely closer to what we're talking about. So this is gonna be to the top for pulling the tissue.
It's kind of like.
If we open this though, will he have the supplies he needs to do the case? Or they don't?
Yeah, they have a whole.
Okay.
Yeah, because I have to show you how to do it, because otherwise he will be there.
This is, it's a, yeah, it's similar,
Very upset. Yep, so here we go. This is exactly what I'm talking about. So you see this section right here, this is gonna clip onto this, okay? So let's feed this
Oh, so it's
down.
one whole piece.
Yeah. So I'm going to fix, but,
And that's your needle for biopsy.
yeah.
I thought we were looking for something little.
This is Sarah. Now, she has worked with Dr. Singh for a minute.
Can you show us
So-
this needle? How
Show them.
he's doing the
How he
needle?
uses it?
Yeah, how it attaches to this, because I'm not
We'll put
familiar.
it down and then lock it.
Like, that didn't seem to be, I was doing that, but it didn't seem to be locking it, so. Okay. It's supposed to lock right onto that piece. Yeah, so.
It is the right one, right?
He always does it? Oh, if he does it and he's not expecting you to do it, then.
Maybe we should let him.
Because I honestly don't use Olympus needles, so. But
Now,
I
we
can
had
at least
a
show you what the needle.
One.
That's
a different one.
Oh, can you show us the one
That's,
that?
that's for EBUS. Is that an EBUS?
Yeah.
Okay, so we had a bunch of supplies up here on top of this tower, and then they were just gone. So
I can't tell you where, there are no needles that were on top of this.
Dory, I don't think that goes there.
Those are all the balloons, and that was.
I mean, it's.
No, I don't think that's
Y'all have
right.
4 steps?
Yeah, we got,
No, so-
it's not for this, not for this.
Well, let me at least show you the needle while they figure out which needle is supposed to go in there.
for the Bronx,
Yeah, these are the ones that we.
That's for the Bronx?
Yeah.
yeah.
Okay.
Yeah, just put that on there so they won't see.
Yeah, I don't know. I had everything up here and it just disappeared, so I don't know.
Well, then maybe Ann needs to be in on this because we have a case as soon as it's done and we're gonna need a needle.
So this is not the one you've been using?
Which one?
So it's probably in.
For this
in
one.
the
For the
health
EBUS?
supply?
Yeah.
That is, it says EBUS on this box. And that is the one that we,
It may be a sterile supply.
Yeah.
I haven't seen it.
The Olympus says
No,
EBUS?
they're
They're
disposable.
That's,
what size is that one?
where does it say EBUS at? That says Olympus.
21.
Yeah.
Here, what's your name?
Maya.
Maya, it goes step 1 through 6, so maybe you can look at that.
I've never used these
And-
before. I'm used to Boston Scientific needles. They're the needles that are recommended to go with our stuff, so.
So that has to go.
Yeah, but these are designed to fit Olympus scopes, and this is not an Olympus scope,
Oh.
so I don't.
So maybe he's been using.
You said, which one, this is designed for the Olympus scope?
Yeah, these are Olympus needles.
Oh, okay, yeah, that's
Weird.
what- yeah.
Yeah,
This-
these,
So how we gonna do this?
because the way they usually go in while this issue is being resolved
Okay.
is it's gonna go in, you know, typically, you'll notice, and this is one of the reasons why I know this is not, for us, is that it goes all the way out. It doesn't fit.
That
So,
might hurt a little.
yeah, so this cannot be used because that's gonna be a lung puncture.
That didn't damage the EBUS scope, is it? It's not
No,
supposed to
because
come
the
up.
way it comes out, it will come up this way from, you see, it comes
where did
out.
it come out?
It comes out just between the lights.
Under the light.
Between the lights there, it comes out. But
What did she say?
if he's using this, I'm not sure how he's using it. And so,
It says adjust the length and confirm
It
it.
says adjust the, can we do this step here? Adjust the sheath length?
yeah, but the problem is we just have to get it,
Let's see, in that picture is what you just showed.
right, see how
Right
that's
here.
on there? Right, except for this is going way out too far.
Yeah.
It should never even be out until they actually, you know, are moving it.
Okay, let me see if you can.
Like, honestly, I don't even know how to use this needle. I have never seen.
So
this
maybe he
needle.
wasn't using that one, because there's
That's
an
what
Olympus
I'm
box there.
wondering. But we need to figure it out, because he's gonna be in here in 25 minutes, so.
I know.
She made a good point. What is the Olympus box for? Because I noticed this is all Fuji.
That's a printer.
Oh.
That's some kind of printer.
Yeah, but that's.
Dr. Singh needs to be brought into this conversation, because if he's using this needle, he needs to demonstrate to them how to use it. I don't know how to use this needle. It's not a needle I've ever seen, and it's not designed for our scope, so that's very concerning to me. Yeah, so Boston Scientific is who we usually use for all of our needles. Yeah, I don't want their, I don't want to give you any bad information, but typically, just so you understand, the needle will go down there, it's attached here. The doctor will then move the sheath down, and typically the sheath, where you want it to go, is, as I told you, right to the end of the scope.
Okay, I found some more goodies. This is
Okay.
an aspiration as well. This is a transbronchial aspiration.
So they brought one of those, but again, I've never seen.
That's for our regular bronchoscope.
Yeah, these are
That's not
the.
That's still not biopsy.
Yeah, but it won't fit this.
But they said when we were tested.
Right.
But you ain't locked it. You can't get no lock.
That's the same thing.
So that's not what we need either.
Well, if he's using that, I just need him to demonstrate it, because I
He had
can't.
a problem with the last one, I remember.
So,
They don't fit.
It's not attached.
Is that much too long?
See,
It comes out the
when I
end.
did this, I noticed that you can adjust this.
Right, that needs to be able to go, right, and that's the needle coming out.
Right, okay.
So once it's in place, then they'll use that to stab the mass. But this has to be, I'm trying to figure out how this, if he's using this and he's attaching it.
And it's got to be locked in there.
And yeah, because otherwise this is gonna move around.
We just did the last one I had lost.
And see how far this comes out?
Oh, yeah, that's way too, yeah.
And that you cannot have that, because when it's put in, it's literally gonna go puncture the tissue. Like, this is not designed to work with our scope, it's way too long.
I wonder what this here is. What is that for?
Well, so that's gonna be for like, typically then,
I guess
they'll
for
use,
this.
yeah, they'll lock that in like that, and then this is when the needle comes up and down, and the needle will go in to the mass. But this is not designed to work with our scope, and if they had some problems in trying to use that before, that would be why. I mean, that's dangerous, that's a patient safety issue. And maybe that was what the issue, I don't know what the issue was last time, so, but what we want to ensure, of course, is safety. And like I said, so Boston Scientific, the way they work, it's literally two separate pieces. It's a tiny little square piece that has a latch. It just clips onto that and closes. And then just that little piece is right there. And it has essentially like a lure attachment at the top.
So it's not even gonna.
Yeah, that the needle will then go into and twist onto. And once that's physically attached, then it has two, so it moves, one moves the sheath into position and one moves the needle into position once the sheath has been situated at the end of the scope. And again, once that's done, then that's when that plunger is plunged up and down so that needle can go, like in, as you'll see here, this is, so you see how this is the plunging motion right there?
This back, and I just explained to her, she's gonna talk to Ann about the sequence, and that we don't have the light after she will be saying the name, which is not right, so. There should be intersection.
Okay, yeah. So once it is in place, then again, that motion will then puncture the lesion, mass, nodule, whatever it is, and it will catch some tissue in there, and then typically then it's withdrawn, and that's, you know, again, that needle is put on some paper that's then given to pathology and so forth. But yeah, this needle, and I can tell you the size of this, when you put it in here, it comes out this far beyond the edge. It is a puncture, that is, it is not compatible. And if this is what they were trying to use before, I could see why they might have had a problem.
I have a question. Are there different long scope? Is this one yours?
No, this belongs to the hospital.
Oh, okay.
Yep.
See, this one doesn't have the measuring thing, so I don't know if it's long.
That's a
You know,
bronze.
That's a bronze.
That's the
Oh,
bronze.
that's just regular
Standard bronze. Right, so I think he brought one in, and we can show you that while we're. I
Okay,
just wanna
quick
make-
question. Is
Yes.
this a suction port or what's this for?
Okay, so that port actually does not get used in these, but they have the same head as other types of scopes. But this is actually an air-water type of port for a standard endoscope. And so you have your sterile water bottle, and it'll have these special tubings on the cap that comes out, and one of them will affix over there, and then one of them affixes to the water bottle. And so then that's how it goes in and out of the scope. And that's for when they press the, like the air water button. So you notice you don't have an air water button. Hi. Hello, hi, I'm Maya McFarland. I'm with Fujifilm. And so I know that I've been trying to get I was trying to get the respiratory staff. I know there have been some changes, so I wanted to train them on how to use it. So this was the EBUS needle they gave me.
Sure.
And this does not fit our scope.
Oh, it doesn't?
No, so my biggest concern, so first of all, it won't fasten properly because it's designed for the EBUS scope, not ours.
Okay.
We use typically Boston Scientific needles.
But
So,
isn't this the one that they're using at Cape here?
no.
They are the ones who actually sent it over to us.
Really?
Yeah.
Then they need to come show you how to do it because I don't understand how they're doing that in a safe manner.
Okay.
And the reason why I say that is when this, so first of all, it doesn't actually like
So,
attach.
well-
So how are you?
where's the other part to it? Actually, it's more attached here. There's the other, the black.
There's,
Oh, the cap? Yeah, so that's what you
okay, so I had never seen this deal, so I'm glad you're here. That will probably provide the spacing. Okay.
let's put it in again.
Okay. Because I was concerned this was coming out, the sheath was coming out the bottom.
Yeah, no,
And I was
it's
like,
safe.
oh my gosh, this could be like puncture, lung puncture action.
This is safe.
Okay.
I've used it.
Oh, you used it, oh, great. Because I was concerned, I was like, this is not. So then, okay, there you go.
Okay.
So see how that works? Now, but even see, so here, the sheath, so it should start with this as high as they can go.
They quit. That's it.
No, that's as high as it can go. But so I will say, this is still a bit concerning for us, that it sticks out this far when
Well-
it's seated.
Well, you can kind of.
Will it go?
Lift up on the whole thing. Yeah, the whole thing. So basically, you want this thing always up, otherwise you're going to injure yourself, okay? And this thing should still go up. Where is it not going up?
Right, that's,
It's going up. Yeah, I think that's the maximum it goes to, yeah.
so just from our perspective, because this is automatically out, now granted, the needle is not out until you loosen it and start puncturing with the needle. But typically we prefer needles that you have to advance the sheath and will never go beyond the edge, just in case this gets caught on any tissue. We want to reduce the possibility of puncture. Because that comes out already before you're even putting it into place, that's just concerning for us from a clinical perspective. Now, if you are comfortable using this, we still feel that this is out. Typically, you can see in this picture.
That's too out, yeah.
Right, so the sheath, we would ideally like to be not past the end of the visual part of the transducer. And then that, right, so we're just.
So how do you get that? Pull up on it. Yeah. So that's what
Okay.
we're down there.
Right, so, okay, so then if you could advance the sheath and just show us, sir, the proper placement, perfect. See how he got that just right to the edge there? Then when the needle comes out, again, at this angle here, that biopsy needle is going to go in and grab the tissue. And as I was explaining to them, I've seen different techniques by different doctors, some depending on how the mass itself looks, whether it's anechoic or not. If it's deemed a mass that potentially might have some necrotic tissue inside, typically then they'll want the needle to go all the way through. They don't want to just go into the center because that might not give them a good sample. So try to get as much of the layers as possible. And again, I've seen some people do like a real strong puncture and slow withdrawal. Some people do a plunging motion. That's obviously your area of expertise there on how you deem it to get the best sample. But I'm glad you got that to work because I have never seen that needle before.
Actually, these scopes are all these needles are interchangeable.
Are they, so I
Yeah,
did
so-
not think the Olympus, because I don't work for
Yeah.
Olympus, so I have
Okay.
never seen one until
Yeah.
literally right now.
Yeah.
I didn't realize they were using
Yeah,
those.
so there are 3 companies that make EBUS, Pentex, Olympus, as well as Fuji.
Right, but we recommend Boston Scientific needles.
Right, but they're all interchangeable.
Okay.
You can use, depends on what you want to take.
So do we know
Okay.
how to use the needle?
Yes, you will need to know how to actually push it in, but she's not a rep for Olympus. So
Right, that's what I'm saying.
But I'll teach you.
Right, and I actually asked if whoever does these needles could come to a demonstration for them
Yes,
as well.
yes, that is right.
And I was hoping that they could coordinate it and do it today, but apparently that didn't happen. But if another time they could, I think that would be very valuable.
Yeah.
But, so that is the most complex part, right there is of course just getting your
Dr.
sample.
Can you type this off and then let's see it again?
Oh, okay. So this is a little complicated, okay? This using the needle by itself. So this is the needle, okay? So first you need to adjust it, and you want to adjust it before you start the procedure itself. So this one is already adjusted. So the way, basically what you want to do, so this should never be up and down, okay? This should always be locked here. Because anytime this is not locked, that means this thing can come down and the needle can come out. And you don't want to be hurting yourself. That's very important. Should always be locked here. The only time this thing opens up is when I'm actually at the target site. When I've localized, I'm at the target site. That's when this opens up, and I open it. And I figured out how deep this needs to be opened up, how deep I need to go in, because I don't want to be puncturing any vessels. We have big vessels there: aorta, pulmonary artery, azygos. We have the heart. We have everything there. So I manage this part. And then this is the stylet on top. Okay, so and we'll talk about this. And then there should be a suction. So right here. So this is very important. Okay. So anyway, the first thing is when before we starting the case, you want to adjust your needle. So you want to just you want to make sure you have this part. Otherwise, you're not going to be able to secure it. And so once you're down, so I'll be asking you to insert, or I'll be asking you to give me the needle once I'm at the site. I've localized and I'm at the site. So this is about the right spot, where I want the needle to be adjusted. So the way you can adjust the needle is by going up and down here. So let's see, this is flexible right now, so I lock it. So now I cannot pull it up or down. Okay. Now what I do is, using this thing here, I can either pull the needle up or down.
I think it is, man.
Yeah, this. So up, so it comes out completely, and this thing. I think at that time when you were trying to pull it in, I think it was flexed. The scope may have been flexed, and that's why it wasn't actually moving out a whole lot. Yeah.
But that's what we are going to be doing.
Yeah.
Okay.
Yes, please. So that's how you adjust it. Okay. So now this is adjusted right. This is just about right. Okay. Now, so that's good. That's all what we need for now.
Do you want to show them the suction?
Suction. Okay. All right. So there are different ways of how people use suction. The way I like doing it is, so this is a stylet. So once I go into the lymph node, then I'll have you guys remove the stylet. So you basically push it up and down a few times so that we are able to get those bronchial cells out, all the out, and completely remove this. Then
Is it like an out, in, out?
yeah, this is a stylet.
And like-
Yeah, in and out. Yeah, and I'll do it initially, and I'll show you how to do it. And then what I do is I'll measure how much deep I want to go in, and I'll lock this here. Okay, so I'll have to lock it. It has to be locked. Then I'll jam it in. I have to go through the trachea. There's cartilage, through the lymph node, so I have to actually jam it in. So that's why I need to make sure that this is locked. I don't go too deep, because if I go too deep, I might enter one of the blood vessels, the heart, or all those important vessels there. So then I push in. So once I push in, once I jam it in, that's how I'll jam it. Okay, it's like throwing a dart. So the needle will come out. Okay, so that's the needle. So it's a needle. Okay, it's a fine needle. So that'll come out. And then I'll make a couple of movements up and down. But before I do so it'll depend. So let's say there's a vascular structure and patient is bleeding, or there's a high chance that the patient might bleed. Then I may not apply suction to it. But let's say if the patient let's say for example someone has cancer, so lymph nodes will be highly vascular. So in that case, I might not really have you guys put in suction. But let's say if there is just a regular lymph node, and obviously cancerous, but less risk for bleeding, then in that case I'll have you put in suction. This is what I usually do. So basically, you put in suction here, pull it, and then lock it. Let's see. So it's not locking right now because there's no suction. But you just turn it and then you lock it. Okay? And then it'll lock. Okay. Yeah.
So why would you use this?
This thing.
Yeah.
So what some people do is I think they apply suction. I think what they do is so what they do is they apply suction here and lock it. Let's see.
All right, hold it in place.
I think let's see. Okay, so yeah, so that's so they already apply suction to it, and then once I'm in the vessel, then what they can do is they can secure it here and then open this thing up. So you already have some suction in there.
Right.
I guess depends, yeah. So okay, so that's kind of what you do, and so the needle is already out. Okay. So I have to make sure before I leave the lymph node that this needle is in, because I do not want to contaminate it. So I pull it out, and lock this, secure it up, the needle is out, and that's when I remove this needle. And then I'll hand this over to you guys for getting the specimen out into like either formalin or one of the other.
Okay, show us how we're going to take that
So do
specimen
we have to
off.
clip it
Do
on?
we clip it on?
No.
Push it out?
So then what you do is then using the stylet, you push the stylet, so this is not secured. So I don't like these needles. These are very old needles actually.
Oh.
So these were like, when I was working, these were in the VA. So even VA was phasing this thing out. But they use it at KFA, that's how we have them. Okay.
Would you be allowed to purchase the Boston Scientific needles?
I have never used Boston Scientific. I have used Olympus. I'm okay with them. Boston Scientific are good needles. I've heard that they're very, very slick, very easy. But I really don't have much experience with them.
Yeah, so what we like about them is that instead of just having that bevel, that single beveled edge, where you're slicing into the tissue essentially with like one little blade like that, the needles actually have 3 points that go like this. So there's 6 surfaces that are cutting into the tissue. So they tend to grab a bit more tissue in terms of their usage. And they are just a little bit easier they just have 2 of these knobs that you twist and to lift up and down for the sheath, so it tends to be pretty easy. Now, if you are required to use these, that's fine. But I'd be happy to talk to Ann too and see if she could at least just get you maybe a couple samples for you to try out and see if you like them. If not, and it may just have to do also with whatever Cape Fear's GPO is. I don't know if but you clearly get other needles from Boston Scientific, because I know I saw the other ones that you have, so maybe that's an option. But as long as you are comfortable with these Olympus needles, then that's great. And I had
get this. Oh, go ahead. I'm sorry.
Oh, no, that's okay. So I had just gone through the whole process of doing the setup for them and explaining the functionality on the keyboard, as well as how to test the balloon and have it ready for you and know that it had already gone through testing. before the case starts. Is there anything else, sir, that you would like me to
Let's
focus on?
let's start with our case and
Okay.
I do have another question again, so Dr. Go back to, how did you say we get the sample
That's
out
all good.
after we put, you said we put this in,
Yeah.
and then we're gonna put,
I'll show you how to do it. Like when we actually do it, I'll show you.
Okay.
Yeah, because this way, like there's so many parts to it. It's very confusing. Like if I just the process of using this needle is very complicated, right? so I'll
Okay.
I have a question. So when, like, this part is wrong up here, and you mean to lug your suction, which is your syringe.
then I'll have you guys do that.
But that one, what do you mean, like, suction? Like, isn't this your suction port?
Oh no, this is a different section. This is not a needle.
Okay.
Yeah.
Oh, okay, okay.
Just so that it's not.
Puncture. Then with this, you aspirate into the needle for your sample.
I'm gonna get it to everybody. I watched it do it.
for the regular suction, like,
No, that's somebody's gonna get some.
Yeah, that's a different section.
yeah, like, for our wall suction.
Yes.
Now, the
You got a shot. About ready?
Maybe a bigger.
Cytolite. We need cytolite. I think that's the blue one.
like the little booster.
No, no,
You
no.
don't do any slides?
No, we don't have the pathologist here anymore.
Okay, I mean, I was.
Yeah. Cytolite. I think they should have cytolite.
Yes.
Yeah,
here.
that's,
Yeah, because it depends on what pathologists want. So I think KK pathologists want us to put in cytolite. So that's what we do.
I just asked because I know what that is.
so Dr. So I thought the formalin was a little smaller with the white cap, that's what the box. But no.
So formalin also works for it, but it's more work for pathologists. So that's why they preferred us to place it in cytolite. So it just it depends on pathologists what they prefer. So I think cytolite is what they want for us.
Okay, with the blue cap.
That's right. But let's say there may be some patients who I'm concerned about lymphoma, and in those patients we'll be using RPMI medium. So that is in the lab, it's usually frozen, that medium. So that can be kept out for about 6 hours, but it has to be in the fridge.
So who is actually going to be doing the case with you today? Do we know who that is?
Well,
Okay.
there's only one case, so I don't know. Do you want me to do it or you want somebody else? One case.
Yeah, I don't know what your policies are with regard to how many people can be in a room.
Still need
during a
local?
case.
What's that?
You still want local? Local.
Local?
Would you use like lidocaine?
Lidocaine, yeah.
1% film?
Oh, yes, please. The same thing,
Epi without epi.
without epi.
1% lidocaine. 1% lidocaine.
Now, someone brought us in that handy little cap that I was talking about for the EBUS. So again, this may come on. Let me show you what that looks like, since we didn't have this in here before. You see
A
how?
couple of biopsies as well. We'll be doing a few biopsies as well.
So you simply make sure it's in the groove. Lock
So
it.
put this back in standby, is it the same way as, like, you hold it the same way you cut it on?
Yes.
Okay.
Yes, exactly. And think of it, the reason why it's important for standby.
That's okay, I'll take care of this part. We need to speak like this. Yeah, she's trying to explain something.
Oh, I didn't want to interrupt you. That's- If this comes attached to it, again, very simply, you lift up both of the locks. You'll pull the metal pieces over and that cap will come off. I highly recommend keeping that cap basically right here during the case A so it won't get wet. You know, you don't want it here with the other things, but also it's an easy remember then if you have it near here. And again, in standby mode, you'll simply lock it into place and it is ready to go. So are we gonna get started on this case?
Yeah, I mean, we have already.
Perfect,
Just wait for you all.
Yes, so I know a bunch of them want to stay in and watch, but I wasn't sure what your policy was, if you have to get approval from the patient for them to observe.
I know the patient comes here, we can probably ask her if she wants us to leave.
Okay.
Or anyone to leave.
And I'm more than happy to stay in for the duration of the case with you. I think we had planned that. I thought
Yes.
we have 2 cases?
I think anesthesia and more than one.
Okay.
So we'll keep it at one right now.
Okay.
Yeah.
And then, do you have any additional cases scheduled for next week?
Well, there is one, can we schedule someone? I mean, I'm not scheduled, I was planning to do that one. But if you're going to be coming over,
Well, I can work with my, you can check my schedule. I don't know if it's next week, I actually had a consideration about. So, you know, maybe we might need to come on Wednesday, I'd be happy to come back here.
we can do so we have one patient right now, and we can hold that
Okay, for Tuesday, you got so I could use Tuesday.
Who's doing this case with me? Who's doing this case? You doing this case?
I'm just telling you what day to do the next day.
Let me show you what Sherry's giving me. So we all be the same.
Because I need
Working
to.
off of her schedule. Expiration will be
And
26,
then are you
right?
gonna use this insurance? Should I give this to the nurse or?
No. Okay, what you say?
1% lidocaine.
Oh, I heard the 1% lidocaine.
That's what you'll be getting.
Okay.
Same thing.
I just want you to know what you're
Yeah, absolutely.
Usually I like to do like 7:30 in the morning.
And if y'all need stickers, we'll get you some stickers too. 1% Lido, plain, 20 and 20.
So you saying?
Then how much do we drive?
I'll show you.
I don't know. I guess it's up to him and Darlene.
Get another one, so I can do it another day.
Well, it don't matter to me 'cause I gotta go check on my pizza.
Oh, okay.
I just assumed I was gonna be the regular rate, because that's what I was told yesterday.
Probably you two, I would think.
Yeah, you two would be good. Good. Let me see what you want.
I'm gonna get you another syringe.
But it don't
too.
matter, baby, you wanna do it?
Okay.
I mean, close that door.
I think Darlene said you can
Okay.
ask her.
Yeah.
Yeah, it don't matter.
All right, let's see what she says.
But what I can do is. we can
See,
try
he
to-
usually like a little
Two
air
in
right
here.
there.
You just put 2. And
Yeah.
going all the way back up like that. I think it's fine.
We
I'll be
can work
working on
around.
this. Okay, let me know.
Right, it's
I'll get you another.
Okay, so,
But for right now,
You know, it's that just your lidocaine and all of their prescriptions.
Just like make it go faster.
I think so. I think
Beep.
it's fine.
Yeah. Oh, I'm sorry.
That's how y'all do it? I think it's what he told us last
Yeah,
time.
that's it. Put air in
every other
there.
Friday, work at you to help them.
I think the only thing that's new is that
So
before
I
we
could
just had a diluted.
Swap it where maybe I
And
could
like
Yeah, that
now-
was 4%.
That was 4%.
Yeah.
And be available for you on Fridays at first thing in the morning.
Yeah, that'd be great.
Okay, so then, but next week, we still want to do Tuesday, or do you want, because next Friday is one of my due days, so I can't.
Sure, yeah. This is Tuesday.
When do we got that epic class? That's next week. Next,
I think that's like the next.
next
Hey,
week.
darling, say.
Don't forget the epic class.
Let's do 1:30.
1:30.
1:30 or 2.
I think ours is on the
I don't know what day the schedule is, but
That should be
Is
fine,
that
I will
enough?
double check my calendar, if my phone just.
So you do 2 lidocaines and 2 steroids?
That's what I think that's not normal. I just labeled everything. Because Sarah, she's normally the one that's in here. And she the one normally do it. I just remember this a little bit she did last time.
I've only observed one case.
So you done this? You done this? Where you with it?
Realized that they were using that needle and I
Well, the
started
part,
here.
the part that's hard for me is just
So I was so
Right.
caught up with watching the various
Right.
navigation that I wasn't really paying attention to the needle was Dr. Locklear, so.
Most of
Y'all can put it wherever y'all want to put it at, I guess.
Right.
Yeah, that's what I'm thinking, so I'll talk to the patient tomorrow
Well,
morning.
that's why we need to do this. Right.
So there's somebody who's looking forward to it.
Everybody.
I can actually talk to
Everybody. So we can see.
I think I have one.
Just again,
Right.
if you want to see that.
And then more.
So this
So
will be.
then the other thing is, so the tricky thing there is that there is air in there.
Yeah, so I was gonna say, what I would do right now is get another syringe. So we can just get that very last bubble of air out. Do we have a,
We could, can't you just put
and
the,
then just pull.
can't you just put the liquid all the way up to the, all the way out now, put
Yeah,
it back
let's
on
see if
the-
we can get that out of there. 'Cause we tried and got most of it, but. Okay. Oh, there's still that little tiny bubble in there.
All that air is just going to be
Yeah. Do we have a plain, just a non-water filled syringe that we can just suck that out with?
Let me get you a
Yeah, because there's that tiny little bubble and air